I wanted to talk to you a little bit about the total hip replacement procedure. This surgical procedure is one of the most successful procedures that we do and has some of the highest patient satisfaction. It is used for the treatment of pain secondary to arthritis of the hip. And with pain in mind, it has excellent success. There may be some improvement in range of motion, strength, and function. However, motion, strength, and function are not as reliable as pain relief. And the main reason that people come to us to have a hip replacement is to relieve their pain. This is typically done under spinal anesthesia with some sedation. This is a major open operation. And it can be done through either a posterior approach, which is through the back, through a direct lateral approach, or through an anterior approach. The majority of the time we use the anterior approach, and there are a number of advantages of the anterior approach. It allows us to do the procedure in a supine position, which our anesthesiologists like particularly because they have better control in that position. It allows us the ease of intraoperative X-ray coming from the other side. And it allows us to do the procedure through an intermuscular and internervous plane. The nerve supply to the muscles laterally and the nerve supply to the muscles medially are different, so we don't have to, and we're able to split between the muscles rather than cutting down through muscle in order to get to the joint. The procedure takes a little bit longer to do when you go through the anterior approach, but it is easier for the patient because we're not cutting through muscle or detaching muscles, which allows patients to recover function more rapidly postoperatively. There is also the advantage of a slightly lower dislocation rate and the opportunity to restore normal biomechanics more reliably and more consistently through the anterior approach. Not all patients are candidates for the anterior approach, but it is the approach that we use most commonly. So the procedure involves exposing the hip joint between the muscles. We then dislocate the hip, we cut off the femoral head, and then we prepare the acetabular socket. And this involves hemispherical reaming of the acetabular socket, and then we fit a porous-coated acetabular component. We prepare the femoral side with broaches, and then we perform a trial reduction. And on the trial reduction, we're looking at it both clinically, and we assess the shuckability, the leg length, the stability of the hip, and we look at it radiographically, and we look at the level of the femoral cut, the leg length, the leg offset. We look at the fit and fill of the femoral component. And then on the acetabular side, we're looking at the position of the cup, the center of rotation, the fit and fill and the interface between the cup and the pelvis, and in particular, this lateral abduction angle or lateral opening angle, as well as the androversion angle, to be sure that the cup is in appropriate position. And once we have tested all of those parameters, we select the definitive components, and the definitive components are placed. These are typically porous ingrowth prostheses where there's a roughened porous surface on the exterior of the component, and there's a tight press fit, and then the bone will grow into that porous interstices of the component so that you get this composite fit. Immediately upon placement of the components with a very tight press fit, they will support weight bearing. Once we've placed the definitive components, we reduce the hip and we recheck all of those same parameters. We check the shuckability, the stability, the leg length, and then we look at the femoral and acetabular parameters before we actually close. Now, this procedure takes a couple of hours to do. For your family in the waiting area, it will be longer because there's a fair amount of setup time at the start, takedown at the end, back to recovery, x-rays in recovery, orders, dictating operative report. So it's closer to 3 hours before I will have the opportunity to speak to your family. But the actual surgical procedure is about 2 hours. It should be noted that joint stability takes priority over leg length symmetry. And there can be leg length discrepancy. Typically, discrepancies under 0.5 centimeter do not require treatment. Discrepancies between 0.5 centimeter and 1 centimeter are optional to treat, and typically discrepancies greater than 1 centimeter are treated with either a heel raise or shoe insert or a shoe raise. When we do total hip replacement, there is always blood loss. And most patients do not require transfusion. We will allow the hemoglobin to drop down to about 8, hematocrit down to about 24, before we actually consider adding a transfusion. But of course, this will be dependent upon other medical factors in making the decision and how the patient's doing. Typically, less than 20% of total hip replacements will require a blood transfusion. Post-operatively, we do have you full weight bearing. And so you can get up and walk the day of surgery. This is occasionally modified due to intraoperative findings. For example, if there was a femoral fracture that required cerclage or internal fixation, we have to be modifying the weight-bearing status, or if there is soft tissue repair that required protection, we would modify the weight-bearing status post-operatively. But the majority of patients are full weight-bearing after hip replacement. Discharge home is typically the day after surgery. There are some patients that have gone home the same day, but the majority will go home the day after surgery. And that's because you need to meet certain criteria in order to be discharged home. You have to be able to get in and out of bed. You have to be ambulating with a walker independently. You have to be able to get back and forth from the bed to the bathroom, get on and off the toilet. You have to know and demonstrate that you know hip precautions. And we have you negotiate stairs. Particularly if you have stairs at home, you have to demonstrate the ability to negotiate stairs. And even if you don't have stairs at home, it's good for you to know how to properly do stairs. As far as your discharge home is concerned, we also have to be sure that your blood pressure and your vital signs are normal and stable, and that the blood work is within acceptable parameters. And this seems like a long list of criteria to meet in order to allow discharge, but the majority are able to meet these criteria and ready for discharge home the day after surgery. When you are discharged, I will be providing you with prescription for pain medication, and this will be based on what we have found is working for you while in hospital. Typically we use mild, moderate, and severe pain medication. Mild is Tylenol, moderate is Tramadol, and for more severe pain we use oxycodone. Of course, if you have allergies or intolerances to any of these medications, we would adjust accordingly. But the typical regimen would be 2 Tylenol and 2 Tramadol 4 times a day for baseline, and then adding oxycodone for breakthrough. Some patients may actually require more or less depending upon their age, weight, and pain tolerance. Percocet is a combination of oxycodone and Tylenol. We prefer to separate the Tylenol so that you have full dose Tylenol, which may decrease the oxycodone needs. And at the upper end, if you need more, you're not limited by the presence of Tylenol if you're taking Percocet. So we use Tylenol separately from the oxycodone. And the oxycodone is a 5 milligram tablet. It can be broken in half, 2.5 milligrams. So you may take anywhere from 2.5 or half a tablet up to 2 tablets, which would be 10 milligrams. And that can be used every 3 or 4 hours or longer. You only need to add the oxycodone if you're having significant pain. The goal is not to bring the pain to 0, but to bring it down to a manageable level, a 1, 2, or 3 on 10. I probably wouldn't add oxycodone. If it gets to be a 5, 6, or 7 on 10, then I would be inclined to use it because it's easier to keep under control than to get back under control. Now, both the tramadol and the oxycodone tend to be constipating. So I will provide you with a stool softener, Ducosate, which is the same as Colace, and I would ask that you take that twice a day for as long as you're on any of the narcotic pain medication, either tramadol or oxycodone. If that's not sufficient, then will provide you with Senna, which is a laxative to help keep you regular. And once you're off both tramadol and oxycodone and just using Tylenol, you won't need either the Ducosate or the Senna. You'll go back to your usual regimen. In addition, I'm going to provide you with a prescription for Celecoxib or Celebrex, 200 milligrams once a day. You'll take that with food. And that's an anti-inflammatory, which also has some benefit in trying to minimize the likelihood of developing heterotopic ossification, which is bone formation in the soft tissue about the hip. Alternatively, you could use Aleve, 2 Aleve, twice a day with food, is anti-inflammatory and has some prophylactic benefit against heterotopic ossification. Finally, I'm going to give you a prescription for baby aspirin. That's the 81 milligrams enteric-coated aspirin. It's available over the counter. And I'll have you take that daily for the first 2 months as part of DVT prophylaxis. You will be provided with a home VenaPro system, which is a sequential compression device that is applied to the leg and allows compression and massage of the soft tissue to minimize stagnation of blood in the leg to decrease the risk of DVT. And you'll use those sequential compression devices at home for the first month. You take them off when you're up ambulating, but when you're sitting or lying or sleeping, you'll have the home VenaPros on, again, in combination with the baby aspirin to try to minimize your risk for DVT. Now, there are some patients that are at high risk for DVT, in which case we will have to use anticoagulation. But for the majority, aspirin and the home VenaPro units, these are rechargeable, battery-operated sequential compression devices, which you will be provided before surgery, and so that you can learn how to use them so that you're ready post-operatively. And that combination of the SCDs and the baby aspirin is sufficient for DVT prophylaxis for the majority of patients. I'm happy not to have to use anticoagulation because with anticoagulation there's a tendency for more bleeding, bruising, transfusion, hematoma, hemarthrosis, even the need for IND and potentially even infection. So the simplified version of DVT prophylaxis is a welcome evolution. In terms of your post-operative physical therapy, we typically have you start that within the first week, so that if you have surgery, for example, on a Monday, you would anticipate being home on a Tuesday and start your outpatient physical therapy on Friday. I should add that when we do the anterior approach, there's commonly some numbness on the lateral aspect of the thigh. And in about 15%, that numbness will be permanent. When we do total knee replacements, everyone's numb on the outer side. With hips, it's not as common, but about 15% will have that lateral side numbness. You will also initially notice some sense of weakness, and that will gradually and typically improve over time. And you will initially have some limp, which will also improve. In a small percentage of patients, there will be permanent weakness and permanent limp. And limp is multifactorial, not just muscle strength, but biomechanics, leg length, and there may be ongoing perceptible limp, even though I would anticipate that it would be significantly improved compared to your preoperative status. Finally, I wanted to mention survivorship. Total hip replacements are associated with high satisfaction, but it is a mechanical device. All mechanical devices will eventually fail. And as we look at the long-term survivorship for hip replacement, by 5 years, it's still 95% successful. And if we think of relatively conservative estimates for survivorship, by 10 years, it's about 85 to 90% successful. By 15, it may be as low as 70%. And by 20 years, up to half of hip replacements have needed revision. Our goal is to do even better than that, but eventually hip replacements will fail. There are various mechanisms for failure, including wear, loosening, fracture, dislocation, pain, dysfunction, and of course infection. The good news is that the majority do very well and last for many years. Finally, this is really a preliminary discussion to assist you with the understanding of hip replacement. I would like to introduce you to our total joint coordinator, and we try to anticipate your post-operative needs. We actually have an entire binder of information which I'd like you to read over and even read it over twice so that you have a good understanding of what to expect. And understand that I'm really only one part of an entire team that will be dedicated to try to get you the best possible result with your hip replacement. In addition to my office staff and our total joint coordinator, we have physical therapy, occupational therapy, if need be, social services, as well as the preoperative nursing staff, the intraoperative staff, the recovery room staff, and the dedicated postoperative nursing staff on our medical surgical unit. Part of achieving a good outcome is a positive attitude, and I firmly believe that the better you understand the procedure and that if you have a comfortable knowledge of what to expect, then you will feel more relaxed and more confident in the process, and thereby improve your attitude toward the outcome in our goal of achieving excellent outcome after your total hip replacement. Now, this discussion may have raised some questions for you, and I'd be happy to answer them for you. And if subsequently you have questions, please feel free to contact us, and we'll be sure to get the answers for you.